Morning, everyone. How are you? Morning, day 3. Okay, so we're going to be having this fireside chat, and because we're thinking about the way that society and culture influences medical conditions, that we thought it might be nice actually for Aamer to give a more detailed introduction about who he is and how he came to be doing this work. We heard, for those of you who saw Aamer the last few days, you maybe heard a bit more of Aamer's personal journey, but we thought it would be nice for him to share his professional journey as well. So over to you, Aamer.
Thank you. So I grew up in a deprived area in London, in southeast London. My parents came in the 1970s from Pakistan to the UK. I then studied in a primary school, and then when I was about 10 years old, my parents took me and my brother and myself went to Pakistan and stayed there for 18 months. Their parents were at home in England. And then I went through schooling, and then I went into college, university, and became a pharmacist. I had found my A-levels before that, so my parents wanted me to be a South Asian person, being a doctor, but I didn't want to be a doctor. I wanted to read mathematics. In the end, I didn't read mathematics, and I read pharmacy. When I finished pharmacy, I worked in one of the biggest hospitals in London and the UK, and that's Guy's and St Thomas's NHS Trust, and I was there for about 25 years, working there, growing up there, supporting people, and I was an innovator, still am an innovator in my profession.
So can you tell us what that means to be an innovator in pharmacy?
So innovator is when I did things that were nobody had done them before. So some programs I put together. So for example, having placements in the pharmaceutical industry and NHS or NHS hospital. And then I did things where, as the healthcare system was evolving, I was on that peak of that wave of innovating into different programs, and I'm well respected for that in my profession. Long story short, I then, after many years, I did a leadership course, which was the first time in England where non-doctors were getting leadership experience, and that was one of the best years I had in my career because I learned so much about myself and about where do you fit within the ecosystem of health as a professional and as a person. And I make really good friends who I can still call on to say, I need some help with something like this. I then joined the Royal Pharmaceutical Society, which is the professional leadership body for UK, and I was a board member for that, where we made big decisions around the future of pharmacy. I then joined the General Pharmaceutical Council, which is a regulatory body in the UK for pharmacy. I'm still on there as a council member, and I was very much involved with the education side of things when the pandemic came, because we had big issues with trainees, pharmacists and pharmacy technicians and all staff in terms of how do we manage them from a regulatory perspective. And then I also joined we have an NHS blood and transplant service, which is huge in England, in Europe, in the UK. And I'm a lay member for them in terms of the kidney advisory group and the ophthalmic tissue advisory group. And that's helping me to have a wider perspective of health in different areas. I have been a trustee of a multi-academy trust, which is two big schools which we connected together. One was an outstanding grammar school, one was a very poor, deprived area, very poor school, and we merged them together. And then sadly, 2 or 3 years later, we had to dissolve the trust because the performance of the requiring improvements school was so bad that the government took it over. I'm currently working as a pharmacist in a local hospital, and enjoying it. But it's a big change from the corporate stuff that I was doing before.
Okay, thank you. So as a highly experienced pharmacist that's worked in different settings of deprivation in the UK, what do you notice in those areas of deprivation that kind of manifest as social issues that affect medical issues and outcomes?
Yeah, so the social issues is very interesting because where you work or where you live is really important. So if you're living in a deprived area, the people around you are typically going to be deprived themselves. They won't have they'll be speaking a different language. They won't have the aspirations that they could have, and things like going into a professional environment may be too far for them in their minds, and that's not true. So one of the things I did with colleagues from universities was to do access programs for underprivileged students to come into university, to have some experience of university, and then to apply to university, which is a big thing for them. And then we needed to put a support structure underneath because it's a big jump between going from school to university, and if they've not had anybody in their families who've gone to university, they've got no one to talk to from that perspective.
And what about health? So obviously education links to health, doesn't it? And it's people that have better education tend to have better health outcomes. But what kind of health outcomes or health issues were you seeing in more deprived communities?
Yeah, so the thing is with deprived communities is they don't reach out for health interventions. There's loads of pharmacies, there's loads of hospitals, but the thing really is that if you don't go and get some support and help, you won't get it. So what we need to do, and what we did do, is to promote, go to the pharmacy, get your health sorted out. But for some people, there's a stigma around their own health, particularly things like cancer, things like diabetes, things like long-term conditions which are not going to go away. And you can stabilise them, but they can also be on, for life. And it's particularly with teenagers, for example, they are very want to try things. I'll stop my medication because I just don't want to use it anymore. That's a particular thing with epilepsy, for example, where they want to see if I stop my medication, will I get a fit? And sometimes they do, and they think, okay, I've got my epilepsy, I tried this, and I got the reaction, I had a fit, I know that their drug is working, which is really, it's weird that they test themselves like that.
It's quite a dangerous way to see if your medicine works. But and one of the barriers that I think we talked about yesterday was this lack of trust. Sometimes if there's not enough trust, that stops people coming to see pharmacists or health providers such as GP. And how have you found ways to build trust, or you said you've created more awareness of encouraging people to come to their pharmacy and get help. How have you done that?
So I ran a vaccination clinic in a very deprived area of East London, where the community was very, very diverse. In fact, the white British was in a minority in the area, and lots of the population were sceptical around medicines, particularly the COVID vaccine. So there's a whole challenge of trying to encourage people from diverse areas, particularly Black Africans and South Asians, to have the vaccine. And because they were skeptical of the vaccine itself, because of what they heard on TV, what they heard on social media and things like that, they were reluctant to do that. But when they did come to the clinic, my question always to them was, why have you come? If you're so skeptical about the vaccine, well, why are you here? And then they thought about that and thought, well, why am I here? I made that effort to come here. I drove here. I paid for parking. Here I am in the clinic, and you don't want the vaccine. Well, you've made the effort. Let's have a conversation about it. And then, at that time, at the beginning of the pandemic, we didn't have enough of the knowledge that we now have around the vaccine, and we had to reassure people that it's safe. But a lot of what we were seeing on the news was, people are dying, X number of people are dying, and for about 2 months, the news would always report we've had this many deaths every week. When you connect that with the actual population, it wasn't as much as we thought it was, because the numbers just elevate things.
Do you mean the deaths from COVID, or?
The deaths from COVID
Yeah.
Was troubling at the beginning, and also the infections, because there wasn't no testing at that time. And then once we got the testing going, then you still had to, still had false positives and false negatives. But what I did was to make sure that reassuring these people, the population, that I'm South Asian, I've had the vaccine, I'm okay. That doesn't mean that you're going to be okay, but it means that lots more people are taking the vaccine and having the vaccine. You do have some side effects, but it's a longer-term thing. Some of the challenges we had was around people who were breastfeeding, people who wanted babies, and they were trying for a baby, and the pandemic came, so they have to put that off because it's too risky, and all sorts of other myths around the vaccine itself.
So you were saying that within the UK, which is a multicultural society, that there were specific communities at the beginning of at the rolling out of the COVID vaccine, that specific ethnic cultural communities that didn't want to take it, and one of those was the South Asian community. And then as a South Asian, a British person of South Asian descent, you were in a position to be able to reassure people that it's safe to take the vaccine. I just wondered, how did it feel to be, were you interacting with anyone who maybe you would consider part of your community, or how did it feel to be sort of reassuring and saying it is okay and it could save your life?
It was one of those situations where you are trying to give people good news and saying that it's working, you should have the vaccine. But we have to caveat that with the side effects that came with the injection. So you had injection site pain and things like that. And one person just needs to say that, I'm not going to have the vaccine because my friend over there had the vaccine and they hurt they got a bruise on their arm, or they had the flu-like symptoms. I'm not going to have it. But what I said to them was that the flu-like symptoms are the body's way of working, and if you wait a week, that will slow down and you'll go back to normal, because you get pain from flu. If you give flu to somebody, they have flu-like symptoms for a little while and then it dies off. I wrote some blogs, I did some videos, and put them out, and I worked with a few people around the country in terms of translating some of the information into languages that particular community needed.
Yeah, so you were translating health education information about the vaccine into locally spoken languages?
Yes.
And were you changing the wording at all? Did you make it more easier to understand?
What we did was the government had, or the NHS England had, or the government had an English version. So what we did is we just used the English version. We didn't want to stray too far away from the message that the that the government was using. So there was bits where we had to just change the language a little bit, but we wanted to make sure that the message was the same for everybody in whatever language I was speaking.
And did you find after doing that sort of concerted messaging campaign that was culturally and language relevant, did you then find that there was more of an uptake in people taking the vaccine?
Yeah, it was slow to take up because people had to have the vaccine, not have the side effects, and then tell the other person, and then it just grows and it grows and it grows. But again, the news at the time was very negative, very scary. So we had to, the leaflets are there, but you need to have that one-to-one conversation with somebody to look after themselves as well. Because it was very scary. Everybody was scared. Everybody was wearing masks, which is strange. That London was silent because everybody was working at home. So there was no such thing as normal at that time.
Yeah, it was a very strange new normal, wasn't it?
Yeah.
Okay, and then we were talking earlier about how, as a pharmacist, we sometimes think that medical issues sort of can be things that are quite universal, but that actually there can be sort of racial differences in the effectiveness of medicines and of the specific medical conditions that can be experienced. Could you tell us, as an expert, a bit more about that topic?
So there is something called genomics, which some of you might have known about already. And genomics is when they map the genomic profile of a person, and then some medications will have a better effect based on the genetics, and some will have a detrimental effect or no effect. And that way, there are some medicines, say like with black African people, when they have their blood pressure, they take the recommendations in England is you take certain medicines which work better for that cohort of people, and you wouldn't necessarily give the other medication to those because they're less effective. And lots of research has been done on that, particularly in the black African community. That sort of research hasn't been done in the South Asian or other communities in the same way.
Oh, really? So there's still a big research gap amongst the South Asian community. So is that the South Asian community that lives in the UK or South Asians in general?
I mean, say South Asians in general, but we can't generalise too much.
Yeah.
But because we have in England or in the UK, we have the older generation who've come from their home countries into the UK, but then you have people like myself who was born and bred in the UK. But our genetics will still be our genetics. But the point is that we're trying to get into a place of precision so that we can tailor that particular drug for that particular patient as an individual basis. And that's what pharmacogenetics is all about.
Great, so that there's more specific medicines that will be effective for
Absolutely.
a particular condition.
Yeah.
Yeah, because it's quite a sensitive topic, isn't it, I think? But it obviously has to be discussed, and it has to be the subject of research if we want medicines to be really effective. And we talked also about sometimes there's kind of cultural barriers and particular medical conditions that are maybe more common in different communities. What do you notice around sort of amongst, I mean, they're not really your constituents, but the people in your in your neighbourhood as a pharmacist?
Well, the thing with South Asians is that our diet is, a Mediterranean diet is very healthy. A South Asian diet is not healthy, in the sense of that very oily, very rich foods, and people don't exercise as much as they should do, so they get obese, and then they get more difficulties because of their obesity, and because they are not having a balanced diet. So they still eat the traditional food that they would eat in their own country. And in their country, say in Pakistan, where I'm from, we're still getting that people who are workers, they burn off the energy. Whereas when you're sitting at home in an office, you're not burning anything off, and therefore you are at a higher risk of things like diabetes.
And of course, white communities in the UK also have a really high rate of obesity, and like you said, that may link to lifestyle and still eating food that was maybe originally designed, meals that were sort of designed to enable people to go down and work in the mines, which was very hard physical labour, but instead, you know, maybe sitting for long periods of time in an office, where there's maybe less calories.
I think the thing is that in olden days people would walk around and do manual labour. Nowadays people sit on a computer. You know, I worked for 9 months from home and sat in that same chair every single day and didn't really go out as much as I could have done and put weight on. It's inevitable. Yeah.
And so of the sort of medical issues that you encountered, which ones do you think are preventable and we could maybe go further to prevent?
Obesity is one where, because it's sort of man-made, we've done it to ourselves. And we can change that through lifestyle advice, your food intake advice, exercise, things like that. And that's not necessarily reversible for everybody, because some people will be obese anyway. That's just their genetics. But that's one area where in England, in the UK, we are encouraging people to eat healthy, to take exercise. And many places are promoting exercise, even going for a walk, or they call them park runs, where you go with other people and you run around the park. And that's not running really fast, that's just taking some exercise and trying to do that on a regular basis, which then gives you, you lose some of the fat, it gives you well-being because of the endorphins that you're having, and you can socialize with other people at the same time. Because, you know, during the pandemic, socialization was very difficult because lots and lots of elder people in particular were more alone, and they didn't have anybody to physically talk to because you weren't allowed to go inside their houses.
Yeah, so as a psychologist, I know that, you know, during the pandemic, we had a big uptick in anxiety and depression, and some of that has reduced now that the pandemic's pretty much over. But there's obviously long COVID, and also some people still struggle with anxiety that maybe started in the pandemic. I just wondered what physical health conditions, and probably long COVID is one of them, that maybe increased during the pandemic and now remain in your experience?
So long COVID was something that was new at the time, and there's lots of different things that happened to people who had long COVID. I don't see that necessarily, and you guys might disagree with me in the audience, around is that classed as a long-term condition? Because we're not talking about long COVID anymore. And we're talking about other things. We're starting to become normalized back into how we were before COVID from the physical perspective.
Yeah, and for a while, long COVID wasn't considered whether it was an actual medical condition, but I think it is now. Is that right? Yeah, and that's, I guess, an example of how culture and society influences the classification of medical issues, and that can change over time.
Yeah. I mean, it's a bit like any transmission of any illness, like bird flu, for example. You know, that came, that's gone. We fixed it in terms of vaccinations in different countries in Africa. And the same here, we fixed inverted commas, COVID in the UK, because the vaccine itself has done what it needed to do.
So now, in this sort of post-COVID world, and with your experience as a pharmacist, what are you most passionate about? What would you most like to change in terms of people's outcomes?
We obviously, as a healthcare professional, you want to make sure that everybody is healthy, but you won't get that. That's not going to happen. But we've also got to think about old age, and we've got to think about, particularly where I'm working at the moment, that the patients that I see are 80 years old and above. They can't walk. They've got long-term conditions. They're stuck in the hospital. And the hospital is full of these people. And the relatives want the person to pass away. That's a horrible thing to say, but that's what happens. And then your hospital's clogging up with older people. The way that the funding works is difficult because you can send patients off to to care homes and things, but the care homes are full up as well. So we have a problem of people living longer with a very low quality of life at one end, and then you've got the younger people coming through as well. So we are looking in the next 5 to 10 years that there will be a peak of older people, and the healthcare system has to evolve to manage people who don't necessarily need to be in a hospital, but they can be somewhere else to get treated, rather than filling up hospital beds.
So you mentioned that you're an innovator and you're interested in innovation. So what could be done to sort of address that issue of hospitals and care homes having too many, not having enough resources and beds for elderly people?
So we heard yesterday I think, around virtual wards and people speaking to people from their home. I think that was yesterday. So that is one way of, the patient doesn't leave their house, but they have a teleconference with the doctor and have that conversation, rather than that patient having to come into a building, have an appointment 10 minutes, and then they go back. So I think technology is going to be very good for that, and I know one of the speakers spoke about that yesterday. And then the other thing is preventative. So again, goes back to the whole beginning. If we can prevent the disease, then you're going to get less people coming into hospitals.
And at what stage, for elderly people, at what stage does that those preventative interventions or measures need to occur in order to affect people in the sort of last stages of life?
That's a real challenge. Thank you for that question.
Sorry.
No, you've got to base it on the person. It's got to be person-centered, because you can find an 85-year-old who's fit and well. You can find an 85-year-old who is at the end of their life, and certainly I've seen that. And then you have to adjust the medication based on the family respects as well, in the sense of, the family has to approve this person, so you can then have palliative care, and that will just end their life, and you're not giving any proper interventions. But again, there's lots of ethics about that as well. Sorry, I forgot the question.
So say if an individual had a sort of high alcohol, high fat, very sedentary life, up until age 60 or 65, and then around retirement decided, okay, I'm going to lead a healthier life now, could they change their sort of obviously they could get fit and healthy for those 10 years, but would then that affect their sort of final, we're talking about the issue of hospital beds and hospitals being clogged up and oversubscribed. So, could people in retirement age still change their sort of long-term outcomes?
They can do. I mean, the thing is, depends on what illnesses they've got and their physics, and whether it's a physical illness or not. But I think the thing around exercise is important. Even a walk around is important. Get yourself moving. I think that when people are older, they can be fragile. so they may not be able to watch. So you have to individualize that. Everything, in my mind, everything around health has to be individualized, because you and I are different. I'm different to everybody in this room. And when it comes to death, we can't judge that. Death comes when it comes. And so sometimes we see people who pass away very quickly, and we see people who are, having that death rattle for hours and hours and hours before they pass away. And that can be really hard for the family.
And so just to kind of go back to the issue of sort of obesity, and throughout this conference we've been talking about lifestyle and how you can change outcomes that way. Obviously, in the UK, and it's probably true in other contexts as well, people know that you need to eat well and exercise in order to be healthy, but often we don't do it, So there's another thing, it's not just about knowledge, is that there's a motivational gap, and that's, that might be relevant, to an 8-year-old or to a 20-year-old or to, a 65-year-old. So what can we do to address that motivational gap when people know, oh, okay, I should or could exercise, I could do things that would increase my health span, but there's just a struggle with motivation to actually do it?
I think you have to start somewhere, and walking is one of the easiest things you can do. I think when it comes to diet, people buy food which is full of fat and cholesterol and things like that. Change your diet, but it's habit forming. So if you have a habit of eating badly, it's going to be hard for you to change, but you do need to change. And that person has to have that motivation to do that. And it's a bit like what we talked about yesterday in terms of the first steps are the important steps. If you begin that journey of, I'm going to get myself better, I'm going to do exercise, I'm going to eat well, you won't be doing that every single day, but you will be doing it one day, then 2 days, then 3 days, then it will become normal. So that's a long-term plan, I think, for individuals to make themselves better. Now, when it comes to medicines, medicines are part of the process as well. In terms of, if you've got long-term conditions, you can still do exercise and you can still do all these things. But if you're, for example, you're asthmatic, then you need to be making sure that your asthma doesn't get worse simply because you're taking exercise that's rigorous exercise and you get breathless.
Absolutely. And so I guess there's an opportunity for any entrepreneurs in the room to help people with motivation. So like you said, it's the first steps that count. And, a doctor or a pharmacist can give a person a leaflet that says you need to exercise and eat well to have a long life. But whether a person actually chooses to do that is up to their own brain and up to their own motivation. And so I have a bit of a bias because I'm interested in apps and mental health apps, and sometimes those apps can be used for motivation. So actually, whether it's Noom, which helps people with dieting, or meditation, it helps people manage emotions. But what I know from my research is that within those studies of apps and digital approaches, they tend to be mainly white, middle class. The samples of those studies are white, middle class, educated people. So there's a real gap where the research isn't being done with black communities, with men, with South Asian. And so when we think about research and what we know, although we need to use evidence-based approaches, some of the evidence base is sort of skewed in the UK context anyway, and America as well, is skewed towards evidence from white populations. So I just wondered what you thought how can we address that so that it's more equitable?
So what's come to my mind is that why are those apps exclusively in English? why can't we have different languages on an app where if you come from a particular part of the country and you speak a particular language, a recognized language, why can't somebody put that in the app so then you can click on the app and that they will be writing or speaking the language that you've chosen? Because as the older people from different countries, they may not have English. So why can't we use Polish? Why can't we do Arabic? Why can't we do Punjabi, and have an app? And there are people who are doing that. And then you can give those messages. Because English, as we've noticed, English and American English, as use different words for the same thing. So I think there is a space here when it comes to innovation in terms of language, written and spoken.
It's a good point, actually, because I think the COVID app, there was 3 COVID apps produced by the British government in the UK. I think, were they in different languages, or were they just in English?
English. As far as I know, there was English.
Yeah, so there's a real opportunity there, isn't there? And what about other sources of health information that maybe we're not thinking of? So, if you're trying to reach different communities, and so there's the GP, there's a sort of a general practitioner, there's a pharmacist like yourself. Where else would specific communities get health information or information that would influence their behavior, their health behaviors?
That's a very good question, because most people go to Dr. Google, and Dr. Google gives all the answers. However, Dr. Google doesn't give all the right answers for that individual necessarily. So you do need to go to a health professional to be able to say, this is what I need. Because what can happen is that your rumors can become the truth, and that particularly happened during the pandemic, where people were believing things that weren't true. Now, you can say that not necessarily in health, but anywhere. So you have to look at, you can still go to Google, but you have to look at verified articles from professionals. And even then, when you're looking at, there were lots of diverse thinking around professionals as well, in terms of some high-profile professionals didn't talk about the vaccine in a nice way, in a good way. So I think it is around language again.
Okay, great, thank you. So we're going to go to the audience now with any questions to Aamer. Okay, sir, I see your hands up. Yep.
You kind of touched upon this point, but quite a few countries are actually homogeneous populations, so they're like predominantly Indian or predominantly Japanese. There's no variation of population.
Can you step closer to the microphone, please?
Should I repeat everything I said?
Yes, please.
Okie dokie. So quite a few of the countries have a homogeneous population, so they're either predominantly Indian or predominantly Japanese, blah, blah, blah. And I was wondering whether there's a way to push for research in terms of, like you mentioned, eating habits. There's the cultural aspects, whether you sleep longer, sleep shorter, and then the physiological differences for like mixed races, or to maybe just share, because like I'm obviously Indian, and since there's less than 1% of foreigners, if you go to the hospital, they probably would just prescribe it based on your age and your weight and stuff like that. They won't really think that your physiology is different, which is a huge issue because I'm Indian, but I live in Japan. So there's nothing that's really, they don't prescribe, for example, Allegra for hay fever. They give me a dose that's 1/3 of what I would get in the States. So it burns out and it's like useless after like 3 hours. I'm sneezing again. So do you think there's a way to kind of link the countries or something that might help both mental health and then pharmacists and doctors to approach this problem?
Could you just rephrase that for me?
I think what you're asking is there a way to link information so that when an individual is prescribed a treatment, it would take in their racial identity as well as maybe their mental, the whole, you said often it's based on age.
Yeah.
That's genomics. What we're talking about is genomics. And genomics is connected to your own profile, you see. And there's lots of research going on in different countries and different populations around genomics. Because you're from India?
Yes.
I'm from Pakistan.
Similar.
You're from America, stroke England. So our genomic profile will be individualized and different. That is work that is being done around the world. But it will take time for that to come into fruition where it's normal, where it's every single day. Every patient will have their own individual profile of medicines they can take. An example I was sharing with Mia this morning was around paracetamol. Everybody's heard of paracetamol or acetaminophen in America. We give the same dose for somebody who's 16 years old to 100 years old. How can that be?
Yeah, and I think it also links to some of the topics that have been picked up the last few days around the potential for AI and for to sort of integrate different knowledge sources so that doctors and pharmacists could have kind of up-to-date evidence on conditions. So there's probably a big opportunity there because I think it isn't always consistently known, and I think there's a huge opportunity, isn't there, in terms of making sure that people always have up-to-date evidence-based knowledge practitioners have them at their fingertips. Does that answer your...
Yeah, quick addition. Obviously, globalization and cross-border people marry other races. Still too far. Well, like literally an inch away. So what about mixed race people? I've never really seen anything specific to people who are like, biracial or more mixes. They base it on, kind of one or the other of the parents.
I'm struggling to hear.
So he's, gentleman's saying, so if we know that for some medicines there's different effectiveness for different races, what about mixed race children or mixed race?
Again, that's part of the bucket. The problem we have is with mixed race children, mixed race families, is it's spreading. So you have to start somewhere, you see. So if for example, I'll give an example of my family. So my daughter is Pakistani, her husband is Syrian, and his genetic profile is obviously his own. But then if they have a child, the baby will be Pakistani / Syrian. Now that then becomes very complicated around the world. So that's why you do genomics to find out your own genomic profile. Now the thing that's happening is that the genomic profiling is becoming easier and less expensive. So it's becoming normal. So there will be a time, maybe not in my lifetime, of when you can individualize your genomic profile per that person, and you may well be able to do that at birth or in a few years after birth. I'm no expert in this area, so I'm not saying that it will, but I think the advances of technology, and we were talking about AI and other things, they have just super accelerated everything. And that's why we are having innovations which are much quicker to market, you see. But there's also a caveat that there's got to be some regulation sits underneath it to make sure that you're not having a dog with a cat, if that's a bad example, but I think you know what I mean. And regulation, as we've said in this conference, is slow. You see, so that will then slow things down, but actually that slowing thing down might be the right thing to do as well.
Thanks.
But clearly a lot more research is needed with mixed race children and adults. And I would imagine it's more complicated to form a sample of mixed race, but not impossible. So that, I definitely think that's a new area that would benefit from further research.
Thank you.
Any other questions? Oh, I thought we had 41 seconds.
40 seconds, yeah. Hurry up.
Final comment, maybe?
Is this okay? Okay. So thank you for an excellent topic to start this morning. I think this just, there's a lot of debates that can happen on this topic, so it's a very good start to the day. I just wanted to touch upon the point regarding the motivation. So yes, you mentioned, Aamer, that we can give baby steps to the patients. So I think we have come a lot ahead with the suggestions now, because patients know. They come to us and they say that, I know you're going to recommend me to start walking maybe 5 minutes a day, but I don't want to do it. So I have seen that patients, their why is not clear. For example, if you tell me that, oh, you should start walking. I know the benefits of walking, but being a doctor, I know it, but I still don't have motivation to get up in the morning and go. So most of the times, patients, their why is not clear. So I think, Mia, being a psychologist, I'm sure you must have consulted patients on motivational interviewing and different techniques for healthcare professionals to learn more about how to deal with it, because ChatGPT has taken over all baby steps to start with. How do we as healthcare professionals change the game, up our game, learn more about the techniques so that we can be ahead of AI and try and up our skills? Because I think it's a very important thing for us to upscale things and learn about these techniques which are around. So Mia, what are your suggestions on using motivational interviewing for healthcare professionals and getting that as a part of everybody's curriculum, or upping the research game on that? Yeah, thank you.
Yeah, I'll keep it really quick because I know we're out of time, and I do apologize. Yeah, so there's a huge literature on this, and it's worth looking at behavioral activation, because that's the complete focus. But I also think the other thing is that if someone values their life, so if they care about themselves completely, then they care that they're going to live a long life. So there's also a self-esteem aspect. When people don't want to do anything to help themselves physically, I think there is also an emotional dimension to that. So then you need to also help people at an emotional level to want to be physically healthy, and to want to be physically well and to be the best that they can be, right? And if people have kind of given up on that and they're just living to be alive and to eat and to sleep, then there's definitely an emotional and self-esteem aspect that also needs looking at. I think I'll leave it at that. But a great point, and definitely, I do think you're right that psychologists, therapists, pharmacists, and doctors need to work together, actually. Yeah.
Thank you. Ladies and gentlemen, please put your hands together for this incredible chat this morning. Great way to start the day. Nice mix of personal and scientific approach. All right. Thank you very much.